Hi and welcome to our Conceive Baby discussion today. My name's Tasha Jennings, and today we will be talking about an aspect of fertility that gets us a lot of attention, and I think most of us would know a lot about, in theory. But we'll be discussing IVF. We'll be discussing what is really involved in assisted reproduction, what your options are, what you can expect, how it really works. So if you're considering IVF, you're in the right place. And I'm thrilled to be speaking with a true expert in this field, Professor Michael Chapman. Professor Chapman is one of Australia's most highly profiled and respected fertility specialists. Dr. Chapman is the co-founder of IVF Australia. He is a busy clinician who has personally been involved in fertility care resulting in over 3,000 pregnancies. His academic position enables him to be at the forefront of new advances in treatment, which he applies in his practice at the earliest opportunity. He has a high public profile due to his tireless efforts to ensure access to assisted reproductive technology for all Australians as a vocal patient advocate and senior medical academic training practitioners for the future. Welcome, Professor Chapman.
Hi there.
Lovely to have you, and I'll refer to you as Prof, which is, I know a lot of your patients and friends refer to you as Prof, and as well as in your podcast series, which you also have, the IVF Journey, is that correct?
Yeah, that's right. Yeah. Yes. I've been called Prof since day one.
Yes, yeah. Early days of becoming a professor, or was it even prior to that?
No, since becoming a professor.
Oh, that's lovely. Well, I know thanks for taking time out of your extremely busy schedule to be with us today. I know you have just been in the Channel 7 studios being interviewed there about this exact topic, pretty much is what we're talking about today, is assisted reproduction.
Yeah, the morning program this morning, they seem to be pretty regular these days. IVF is out there and people want to hear about it.
Yes, I think and hopefully that's what we can start to break down today, because I think you're right, people hear a lot about it. We hear a lot about women, older women particularly, resorting to IVF, but what does it really mean? And I know it's a difficult journey for anyone involved in infertility. So going to a fertility specialist can be a daunting prospect. What can women or couples expect when they do first visit an IVF specialist like yourself?
Well, what we're trying to do is to work out why they're not getting pregnant. So obviously they're going to be a whole collection of questions, both for the woman and for her partner in relation to health issues, things that would influence their possibilities of getting pregnant. They'll range from, what operations you've had in the past, what medications you're on, through to, more embarrassing things like, how often do you have sex? Because obviously the only way you're going to get pregnant is to have sex at the right time. It's surprising how many couples, even today with apps that you can, work out when you're going to ovulate, even with those, people still aren't getting it right.
Yes.
So that you can expect a sort of a half hour or more conversation about all of the factors that might be leading to why you're not getting pregnant.
Yeah, it's interesting. I know I see a lot of that, and I did an episode on finding your fertile window and talked a lot about apps, because I see a lot of that in my patients as well, because they are relying on apps instead of understanding their own cycles. So it's good to get to the bottom of these things. And I guess when couples come to see you, it's not necessarily directly to IVF. I mean, there's a lot involved in what you do, and there's a lot of assisted reproductive technologies involved. So I guess, can you explain a little bit about all the assisted reproductive technologies? What are the options for couples?
Yeah, I mean, one of my, with my president of the Fertility Society of Australia hat on, one of the things we're concerned about is perhaps that too many people are going into IVF too soon. We as subspecialists of our college are very concerned that treatments that are simple are being gone past and going on to IVF. So for many couples, in fact, you mentioned 3,000 babies, but probably nearly half of those have been conceived not through IVF, that much lesser treatments are suitable for many, many couples. So starting at the bottom and working our way up, I mean, basically, a woman has to ovulate. And so to produce ovulation or induce ovulation, to make the egg that's going to get pregnant, if that's not happening, then tablets is all you need. And in 70 or 80% of cases of women who are anovulatory, in other words, they're not making an egg each month, tablets will produce the pregnancy they so desire. Then with those tablets, though, one has to understand, and again, one of the big problems I have with patients is the expectation that they will be pregnant tomorrow.
Yeah.
It's what they want. It's why they've come to see me. But the best we can do with inducing ovulation, producing that one egg each month, is turn them back into being normal. Yeah. Now, what's normal? Normal is actually only about 15 to 20% chance of a pregnancy in any one menstrual cycle. Now, it's cumulative. So if it's 15% each month, that's equivalent. I use the analogy of a dice. The chance of rolling a 6 is 15%. How many times have you rolled a dice and not got a 6 when you were trying to start your Monopoly game? That's the statistic, and it is that random chance that for most couples. So once we get a woman ovulating, we're really just putting her back with a dice. So patience is important, and that's one of the problems of our modern world, I think, is the expectation is, oh, well, I've come to you, you're going to get me pregnant tomorrow. Yeah. It doesn't happen with ovulation induction, or it doesn't happen with any of the treatments. As we move up from that, intrauterine insemination is another proven method that doesn't involve IVF of helping couples get pregnant. Predominantly, it's for couples where we've done all the investigations and find nothing wrong. We call that unexplained infertility. And with those couples, IUI does give them a 20-odd% chance per cycle. Again, it's not magic, and repeated cycles are often necessary to achieve the pregnancy. So that's intrauterine insemination. What we do there to enhance pregnancy is to give the woman either tablets or injections to make sure she ovulates really well. And then we time the day in which the sperm is going to be put in, so we've got it at the right time. And then we take the sperm and we put it through a process called a swim up or a trial wash. There are various names for it, which basically, as I explained to patients, is we throw the sperm in one end of a swimming pool and then walk up to the other end of the swimming pool an hour later. And the boys that got to the other end must be the good ones. They're the Olympic swimmers. And they're the ones we then collect together and put inside the uterus. A bit more than a pap smear, not much more than a pap smear. Yeah. So that's intrauterine insemination. That's the next stage up. And then beyond that, we then get to IVF. Yeah. In fact, I get very pleased. In fact, we don't go in some patients, and not irregularly. I see a patient and then they come back for the next visit and they're already pregnant. And maybe just being relaxed a bit might help. But also, one of the investigations that we do to check the fallopian tubes are open, we're flushing through the tubes, either under ultrasound or X-ray, does seem to have a positive effect in terms of encouraging pregnancy when nothing else has happened in the last 12 months or so. That's probably because we are flushing out bits of mucus plugs. Not that there's any damage to the tube, but they're blocking the ability of the sperm to get to the egg. And in the first 3 months after one of those procedures, there's about a 25% chance of a pregnancy. So I certainly start those couples, first of all, having flushed the tubes through, I say go away and try, and come back in a couple of months, and then we'll move on to something else. So there's a whole graduation of stuff before you get to IVF.
Yeah, I like to roll with the dice analogy. I think that a lot of women aren't aware. Sorry, I think we're getting that feedback again, Ross, aren't we? So
Yeah.
I'll see if I can. But women aren't aware that, I guess, when they do ovulate, it's not necessarily a viable egg they produce each month. In fact, it's, you know, a quarter to potentially half of those eggs aren't viable. Is that your finding?
Yeah. So, I mean, the statistic now we're fairly convinced about is that when women do ovulate and are at risk of getting pregnant, they've had intercourse at the right time, probably 60-odd% of cycles actually conception occurs. An egg and a sperm do get together. But by the time the period comes, 2 weeks later, there'll only be 15% of those will be carrying on. So we do lose a lot, and that's almost certainly related to the eggs. As we've got deeper and deeper into pre-implantation genetic diagnosis, so being able to tell the genetic makeup of an embryo, it's quite clear that even at 30, at least half the eggs that end up with a nice embryo are still genetically abnormal. So nature's in a human is actually very poorly set up. We've evolved that way. I put it down to the fact that, you know, God didn't want us to populate the world, because if we were like a rabbit, and every time, or a mouse, and every time we came into season, like, which is 12 times a year for humans, and we were successful every time, which mostly rabbits and mice are, we would have been off this planet, 10,000 years ago. We actually are very poor reproducers, and that produces the frustration that many couples suffer.
Yeah, because it does seem, people think, oh, it's just putting the egg and sperm together, but there are so many factors involved in pregnancy. So it's not just about a healthy egg and a healthy sperm. There's fallopian issues. What are the main issues you see in women presenting in your clinic, and males for that matter?
Yeah. Okay. So, well, let's start with the male first. We know that to get a pregnancy, you need at least 50,000 swimming sperm around the egg in the fallopian tube. And they've made this long journey from the vagina up through the uterus. It's a 7 or 8 kilometer run if it was a human. And they've got to be there in big numbers. So you've got to start with good concentrations of sperm, and they have to be able to swim. So any reduction in either numbers or quality and ability to swim will result in a reduced pregnancy rate. Not zero, because some still get through. Unless you have no sperm at all, then there's no chance. But if there's some sperm, there is always a chance, but just the chances are very low. So why do men have low sperm counts? Well, some of them are genetically determined from birth. Some of them are because damage to the testicles, boys born with undescended testicles, damage to them through infection, mumps in adults, males, can cause destruction of the production line, and so you don't reduce sperm counts. You can get blockages. Some people are born with blockages, and of the tube between the testicle and getting to the outside world. So they will produce, or they will not have any sperm visible on an ejaculation, although in the testicle there are sperm. So the one thing that I have increasingly come across, and quite worryingly, is the increasing tendency for young men to want to look buff and go to the gym, and they take steroids. They look wonderful, but their sperm count is not so wonderful. Yeah. In fact, it can be switched off altogether, and not only in the short term, but also in the long term. So I'm seeing more and more of that, and it's a real worry. So there's a whole range of things that can cause a reduction in sperm quality.
Yeah.
On the female side, I've mentioned already, we've talked about not making an egg. And the commonest reason for that is polycystic ovarian syndrome, present in probably 5 to 10% of the female population. It's the commonest hormone abnormality in the reproductive age for women. It is relatively easily overcome. You know, when I have a patient come in with PCO, I go, oh, this will be easy. Or at least certainly easier than women who may come in with other conditions. And those other ones would be where egg and a sperm can't get together because she's got blocked tubes. So infections, previous operations in the pelvis, endometriosis. And there's a big public awareness campaign on at the moment in relation to endometriosis as a whole. I mean, the government's got involved in it and they're putting money into it, and which is fantastic because it does affect a large number of women, particularly if they delay childbirth. Women in their 30s are the women most prone to getting endometriosis.
Yeah.
Now, there's a whole range of options in terms of treatments, but perhaps we'll get to that in a minute. On the female side, running out of eggs is a worry, and 3% of women under the age of 40 will go through menopause. Now, obviously, if you're not getting eggs, if you haven't got any eggs left, then you're not going to get pregnant.
Yeah. And I think there is that perception these days that you can get pregnant at any age. And I know you spoke on this in Channel 7, actually, in regards to the Bridget Nielsen pregnancy at 54. I guess we could just touch on that. But egg, you know, we do diminish our eggs from the moment we start ovulating, basically.
Well, we diminish even before that.
Yes,
You know, we start with, you know, the most eggs a female ever has in her life when she's 20 weeks pregnant inside her mother's womb. Mm-hmm. From there on, it's downhill. The 2 or 3 million that are there at that point become 500,000 by your time she's born, and by puberty, she's got a couple of 100,000. That still seems a lot because you only need in the whole of your reproductive life around 500 eggs. That's all that will ever be ovulated out of that original 5 million. Yeah. But that slippery slope towards menopause can be faster in some women than others. But that particular pregnancy that was announced last week, she didn't say it, but I will put $1 million on the fact that that wasn't her egg. Yeah. It was coming from a donor, from a 25-year-old. And certainly in the States, there is a vast number of women in their 40s who are getting pregnant and getting to the media, particularly if you're a personality, and they're not their own pregnancies. They are egg donor pregnancies. Now, it's a solution to a problem. There's no question, and we're very good at it. And women in their 40s and 50s can have babies that are healthy and great, but there are risks. You know, older women when they're pregnant, do have a higher chance of getting high blood pressure, of having strokes, of developing diabetes. So it's not without its hazards, but for some, it's where they've got to be when Mr. Right hasn't come along or they've struggled with fertility for many years.
Yeah. So I guess that is another option that you obviously deal with, is the donor eggs and donor sperms as well in regards running to IVF. Yeah.
Yeah. Again, the donor egg does need IVF. The donor sperm can just be with insemination.
Yeah. Yeah. So what are the new advances? Obviously, you're at the forefront of these technologies. Excuse this, repeating that I'm getting. I'm hoping this, it seems to have disappeared. But you're obviously at the forefront of medical advances in IVF. What have you seen over your years of doing IVF, and what advances are we in for?
I mean, it's, being involved in IVF, it's now 37 years ago that I did my first IVF cycle. Mm. And the mum that's been... the first mum, it will be 40 this year. So, you know, I've seen it all and then what's improved is the medications have improved. It's a much simpler process than it used to be. Success rates are substantially higher than it used to be. I mean, in the 80s, we quoted a 10% success rate. We're now quoting 40% in women under the age of 35. So we've come a long, long way. Things like being able to freeze an embryo. It means that we can put one back and keep one or two for another day. which cumulatively means that pregnancy rates are really quite reasonable. We talked about male before, and I think one of the big breakthroughs was the ICSI, the intracytoplasmic sperm injection, the ability to take a single sperm and inject it into an egg and result in a pregnancy at the same rates as nature would be doing. So that was, that's now 20 years old, and many couples have had babies that otherwise they would have had donor sperm or given up altogether. And the way we freeze embryos, I mentioned earlier, we've changed that in the last 5 years, and that's doubled the pregnancy rates from frozen embryos, so they're the same as a fresh embryo. So, it's an amazing field to have been in, to ride the wave all the way through. I mean, in Australia now, we have over 200,000 babies born through IVF, almost the population of Hobart from just doing this technology. 1 in 20 children in a classroom are IVF babies. Just, it's a substantial part of the population growth in Australia.
Yes, I think we're waiting longer to have babies and having issues. So I guess a lot of people are concerned about needles and what is the process of IVF. Once we need to go on that journey for whatever reason, there's blockages. What can a woman expect, and a man for that matter as well, in regards to what hormones, what does a standard IVF process look like for a couple?
Okay, let's run through it. For the man, there's not much other than holding a hand and producing a sample at the right time.
Yeah.
Perhaps not holding a hand at that time. For the woman, it is a highly stressful time, and people have the analogy is the roller coaster ride of IVF, because you start with this huge expectation that you will be pregnant. And you will end up with a 40% chance. But that means 60% of the time, or more if you're older, you're going to not be successful. So you go through the highs and the lows. Having that expectation, I think, is important to start with. And good clinics do provide the appropriate counselling. Our nurses and our actual counsellors in the clinic are there to help the couple through the process. The actual physical process these days usually starts on the second day of the menstrual cycle, when injections begin. So these are injections in the tummy. They are very similar to the injections that diabetics do 2 or 3 times a day for their insulin. They're very tiny needles, very tiny needles. 98% of our women can actually do it themselves, or their husbands can do it. It's very rare that a patient has to come to the clinic to have it done. And then that daily injection will continue probably for an average of 11 to 12 days each day. About 5 days in, it'll be joined by a second injection. The second injection, its role is to stop the woman releasing the eggs too early. Obviously, if we got to the time of collecting the eggs and they're all gone, we've wasted it all. So this drug is called a GnRH antagonist. Lots of names come along here. But it's amazing how expert our patients get with all these names. Pardon me. The first injection we were talking about is the injection to stimulate ovaries to produce lots of eggs. So that's called, predominantly it's FSH, follicle stimulating hormone, and it's a similar structure to what your brain normally produces, but we give it in larger doses than the body does. And what that does is override the internal mechanism that the ovary has to only produce 1 egg a month. So we're aiming to get somewhere between 8 and 12 eggs is said to be the ideal number. So we choose a dose of drug that for that particular woman with her particular hormone profile, her weight and her age will hopefully give us somewhere between 8 and 12 eggs.
Yeah.
So that's the daily dose. After about 5 or 6 days, she'll come for a blood test, and that will tell us that she's actually responding. The ovaries are producing lots of follicles, which produce estrogen, and it's estrogen that we're measuring to make that happen. Then 2 or 3 days after that, she'll have another blood test and probably an ultrasound to actually look at the number of these little black holes in the ovary, the follicles, in which there should be an egg. So we're now about 8 days into the cycle, and she'll come back again if things are going well, carry on with the same medications, and back again around day 9 or 10, by which time we should be in a position to say, well, in 2 or 3 days' time, we'll be collecting those eggs. So, and this is the roller coaster. So we've gone along, had an expectation to start with, and it's all going fantastically. You know, we've got 8, 10 follicles. We've got estrogen levels that are fantastic. And so let's now go and collect them. 36 hours before the time we do the egg collection, there is the third injection. And that's just a single injection, and its role is to mature the eggs, so take them to being having half the chromosomes that will join with the other half from the male, and go through the final stages of that maturation. 36 hours after that injection, we call it the trigger injection, we'll go to the operating theatre. And some clinics it's done under sedation and the patients are awake, others are general anaesthetic. And it takes about 20 minutes, and using the ultrasound through the vagina, we needle each of those black holes, suck out the fluid, and within the fluid, in about 80% of the follicles, we'll find an egg. That usually occurs in the operating theatre. There's the scientist is sitting there with a microscope and looking at the fluid as it's handed from the surgeon to them. And the patient wakes up, and even if they have a general anaesthetic, it's very light, and usually patients are home within an hour after that.
Yeah.
That day is the day that the boy does his bit. Pardon me. And hopefully he produces a beautiful sample, and that afternoon the scientist will put the sperm and the egg together about the time that would normally happen inside the uterus, or inside the fallopian tube, in fact.
Yep.
The scientist will generally ring in the afternoon and let the patients know how many eggs were mature and how it all went, and the next morning they'll ring them again and say, fantastic, of the 10 eggs, you've got 7 fertilized. That's what we'd expect. About 70% of eggs will fertilize. And then we'll follow them on for, these days, we follow them for 5 days to get to what's called a blastocyst. If we get to that stage, that's when we know that we're going to have a high chance of a pregnancy. Of those original 10 eggs, we'll probably get 1, 2, or 3 blastocysts. So that issue that we talked about earlier in this talk about the quality of eggs starts to come into play, and that's why we only get 2 or 3 blastocysts on a good cycle. What we then do, if all's gone well, we'll be putting one of those embryos back on day 5. So the woman will be, come into the laboratory area, and the scientist will load up the embryo into a very thin, soft tube, and then I will push that through the neck of the womb, and the tip of the tube will be inside the uterus. The scientist will then inject it with a tiny amount of fluid together with the embryo. So the woman it's now up to the woman's uterus to do its job. She will know 10 days later whether she's pregnant or not. And as I said, in 40% of cases, in women under 35, it will be positive, and the journey will continue. For the other 60%, sadly, back to square one.
Yeah. It's an exciting process. It's fascinating process. actually. Just to hear how it's explained and what goes on is just really fascinating, how far we've come, probably even in the 37 years that you've been doing it. The technologies available are really amazing and at the forefront of helping women conceive. And I love working on the other side of it. Obviously, I work with diet and nutrition to help produce those quality eggs, and love working with specialists like yourself to see that process then eventuate in a baby, which I'm sure is why you do this as well.
Yeah, I know. It's very rewarding. For 25 years or longer, actually, I delivered the babies that I created. That was, even, when I stopped about 3 years ago, there'd still be tears in my eyes. And these couples that I'd taken from woe to go.
Yeah. It's a big journey. It's a difficult journey for anyone who's listening, obviously, going through infertility. And I think understanding and educating people around the statistics, as well as what they can do personally to help them and assist them in this process and support this amazing technology that we now have available to us to I guess, maximise their outcomes. Yeah.
And I'm a huge advocate of education. I mean, that's why I'm here talking to you. I also have a podcast, the IVF Journey, which is on iTunes. And I hope that, if people listen to that, they also learn a little bit more. And just recently, Liz Ellis, the ex-captain of the Australian netball team, has released a book because she went through infertility and was really passionate about telling other people about it and helping people work through the process. It's I think education is a major part, because going in prepared certainly makes it an easier journey.
Absolutely. I think we share that passion, hence why Conceive Baby exists and why I love speaking to experts like yourself today. And we'll be sure to put a link to the IVF Journey so anyone listening can jump over to iTunes and listen to your amazing podcast and get that education that they need around some of these amazing technologies to help them achieve their baby dreams.
Yeah, and I'm more than happy to help if anybody wants to come talk to me.
Excellent. We'll make sure we put those details there, and I'm sure we will get people wanting to speak to you and listen to your podcast as well. So is there anything you would like to leave us with today that I guess we haven't covered?
No, I think it's been a comprehensive look at why we need to treat patients with infertility, and how it all happens. I suppose that I keep banging a drum, and we all do who are specialists in the field. We see far too many women too late in their reproductive lives, when we know the hope is very small. When a patient walks into the clinic and they say, I'm 27 years old, I go, yes, because the average age of the patients I see, unfortunately, 50% of them are more than 38 years old. And, while I can do my best, I know the odds are stacked against them.
Yeah, I think education is key younger. I'm very passionate about that as well. I see a lot of patients that generally is similar age group as well. And a lot of what I find, you may find yourself, is they've often been put on the pill for fertility, for hormonal issues back when they were 16. They come off now at, 33 wanting to get pregnant, and everything just comes back again, and we've got to deal with all those issues again. And if they had have known earlier to support their fertility health, and I think educating people around what they can do to support their own fertility health is a bit of a missing link back in their 20s. I'm sure I know I was one of those people that at 30, I just thought I would be able to fall pregnant, and it wasn't that easy. Hence this journey started as well. But even as a healthcare professional, there was a little bit of a lack of awareness, or probably a purposely put it to the side, thinking that, we can conceive at any age. So it's great to see that being spoken about more.
Yeah.
Yeah.
Good.
Well, thanks so much.
That's all right.
Time out of your very busy schedule to be with us today. I know you came from Channel 7 this morning. You're here now. You're seeing patients this afternoon. That's just a standard day for you. So thank you very much for fitting us in.
No problem.
Well, for anyone else listening, if you haven't already registered for the Conceive Baby webinar and podcast series, be sure to jump over to conceivebaby.com.au and register there. And also join the Conceive Baby with Tasha Jennings Facebook group over on Facebook. And I look forward to seeing you next time. Bye for now.